Hematology in Primary Care. Dr. Josh Wright, Consultant Hematologist, Sheffield Teaching Hospitals. Referral: hit parade raised HB leukocytosis, neutrophilia/lymphocytosis, thrombocytosis/thrombocytopenia, paraproteins, macrocytosis, low B12, anemia in the elderly, microcytosis/iron deficiency/alpha tau. Common hematological issues in primary care. Lecture. Workshop. Interpreting the blood count. Common referral issues. White cell problems. Platelet problems. Paraproteins. Red cell issues. Erythrocytosis. Hematinics Incorporated low B12. Hemoglobinopathy Incorporated alpha tau. Anemia in the elderly. Any cases brought for discussion. Full blood count normal range. Adult male. Adult female. Range. HB 131 to 166. HCT 0.38 to 0.48. RBC count 3.6 to 4.8. MCV 80 to 98. MCH 27 to 34.2. WBCX 109/L 3.5 to 9.5. Neutrophils 1.7 to 6.5. Lymphocytes 1.0 to 3.0. Platelets 140 to 370. Range. HB 110 to 147. HCT 0.32 to 0.42. WBC 3.5 to 9.5. Neutrophils 1.7 to 6.5. Lymphocytes 1.0 to 3.0. Platelets 140 to 370. What is the definition of normal? White blood count lymphocytosis. History. Male, age 58 years. Hypertension, type 2 DM. Smokes 10 cigs. Drugs. Simvastatin, amlodipine. Exam. BMI 38. BP 140/85. FBC. September 2011. October 2011. November 2011. HB 139. 141. 140. WBC. Lymphocytes. Neutrophils 6.7. 3.9. 2.8. 6.9. 4.1. 4.2. 2.5. Platelets 249. 310. 270. Lymphocytosis. Does the patient have hematological cancer? Should I refer to hematology? Should I continue to monitor the lymphocyte count? Are there any other tests I should do? Lymphocytosis. Primary reactive chronic lymphoid malignancies. Chronic lymphocytic leukemia. Lymphoma. Monoclonal B lymphocytosis. Reactive. Viral, EBV, CMV, HSV, VZV. Stress lymphocytosis. Drug-induced. Septic shock. Myocardial infarct. Trauma. Other comorbidities. Chronic. Cigarette smoking. Autoimmune disorder. Chronic inflammation. Sarcoid. Raised BMI/metabolic syndrome. Lymphocytosis. Malignant lymphocytosis. FBC. Lymphocyte count. More than 10 by 109/L. Lymphocyte count. Less than 10 by 109/L. Anemia or thrombocytopenia. Recurrent infection? Adenopathy, spleen, liver? Abnormal blood film? Yes. No. Refer to hematologist. Repeat FBC, review annually. The neutrophil count. White blood count neutrophil leukocytosis. History. Male age 68 years. Osteoarthritis, CAB 2001. Non-smoker, STOP 2001. Type 2 DM. Drugs. Simvastatin, aspirin, gliclazide. Exam. Unremarkable. FBC. July 2009. December 2010. May 2011. HB. 163. 165. WBC. Lymphocytes. Neutrophils. 15.7. 2.4. 13.0. 17.0. 2.0. 13.5. 14.0. 2.1. 11.9. Platelets. 430. 420. 400. Neutrophil leukocytosis. Acute neutrophilia. Reactive. Infection/inflammation. Neoplasia. Bleeding. Pain. Smoking. Drugs, glucocorticoids. Chronic neutrophilia. Drugs. BMI/metabolic sin. Hematologic. EGCML 100,000. Neutrophil, leukocytosis. Important points. Urgent referral. Greater than 50. Blood film features of CML or CMML, film comment. Consider if. Chronic neutrophilia greater than 20. Chronic monocytosis greater than 1. Chronic eosinophilia greater than 2. History and exam. Infection, inflammation. Autoimmune, neoplasia. Rash, arthritis, weight loss. CRP. UNE. LFT. TFT. CA. Autoab. Microculture. FBC. ESR. CXR. Urine. Reactive screen negative. Hematology referral, neutropenia. Caucasian female age 36 years, no significant medical history, no regular medication. FH rheumatoid arthritis. HB 126 grams/L. WCC 3.1. Neutrophils 0.4. Platelets 180. Neutropenia, neutrophils less than 1.7. What do I need to know? Is the patient unwell? Viral assault transient. Any previous counts? Any other cytopenia? Is the patient on chemotherapy? Other drugs. How severe is it? Mild, 1.0 to 1.7, functionally normal. Moderate, 0.5 to 1.0. Severe, less than 0.5 risk of infection. Neutropenia. What are the common causes? Infection. Drugs, chemotherapy. Autoimmune. Hereditary. Racial, African origin 1.0 to 1.3. Neutropenia pathway. Neutropenia less than 1.0. Consider repeat, particularly if recent infection. Patient on chemotherapy. No. Moderate or severe less than 0.5. Unwell? Yes. No. Discuss with hematologist and refer. B12, folate, LFT, GGT, autoab. Hematology advice/referral. Thrombocytosis, male 65 years, mild hypertension on ramipril. HB 160, HCT 0.50, WCC 11.0, PLTS 450. Refer or not? Thrombocytosis may be reactive to inflammation, infection, other malignancy, iron deficiency or bleeding. In MPD, very high counts greater than 1,500 associated with vascular events and bleeding. Urgent referral. Greater than 1,000. 600-1000 if associated with CBA, TIA, VTE. Consider if. Greater than 600 consistently. Greater than 450 with vascular event. High WCC or HB. Thrombocytopenia greater than 100 functionally normal. Less than 20 bleeding risk rises but most symptom-free. Causes. Immune. Drugs e.g. quinine. Bone marrow failure syndromes e.g. MDS. Alcohol. Liver disease. Pregnancy. Thrombocytopenia refer less than 50. 50 to 100 if other cytopenia or planned surgery/dental work. Investigations. Blood film platelet clumping. Repeat sample. Renal and liver function. Clotting screen. Autoantibodies. Myeloma HB 110 WCC and PLTS normal UNE normal. Total protein 66, 60 to 74. Ig. IgA 0.7, 0.8 to 4.0. IM 0.5, 0.5 to 2.0. MIG 7.0. Ig kappa monoclone. History 68 years female, back pain 4 months TSR 70 X-ray normal. Should I refer to hematology? Reminder, monoclonal or polyclonal? Paraproteins refer if I'm usually associated with lymphoma. Ig 15 grams, IgA 10 grams. Ig-3. Lower levels if associated with CRAB. I'm usually associated with lymphoma. Any other features? Paraprotein 10 grams. Hyperviscosity. C. Hypercalcemia. R. Unexplained renal failure. A. Anemia/cytopenia. B. Bone pain/fracture. Paraproteinemia most will be MGUS present 3% over 70 and 5% over 80. 1% risk of progression to per annum. A few secondary to autoimmune disease and rarely other malignancies. If criteria for referral not met, then monitor on a 6 to 12 monthly basis.